cardiac case. My patient, Mr. XYZ, age 46 year, sex male, occupation working as a lawyer from Cuddalore, presented with chief complaints of breathlessness for 5 months, palpitation for 2 months, and cough for 3 weeks. History of presenting complaints. The patient was apparently asymptomatic 5 months ago when he developed breathlessness. The breathlessness was insidious in onset. Initially, for first 2 months, it was in grade 2 NOHA, then progressing from NOHA grade 2 to NOHA grade 4 over last 3 months, and it was associated with palpitations. The breathlessness increased on lying down and exertion. The patient also had complaints of nighttime awakenings in the last 3 months. The breathlessness decreased on sitting, and it was associated with use of accessory muscle. No seasonal variation was noted, and lately in the past 2 weeks, it has become increased, and there was daily activity limitation. The palpitation were exertional and irregular, noted along with the breathlessness for the past 2 months. It is associated with sweating and sometimes felt during sleep. The cough started 3 weeks back. It was progressive with whitish, non-foul smelling sputum, approximately 5 ml per day, and not bloodstain. The cough aggravated on lying down with no diurnal variation and seasonal variation. Lately, the cough has increased in frequency and limits the activity of the patient. There is no history of fever, no history of fatigue, no history of syncope, no history of bluish discoloration of face and oral cavity, no history of blood in sputum, no history of reduced urine output, no history of headache, and there are no previous history of similar complaints. Past history. When the patient was 16 years, there was an episode of low-grade fever with severe joint pain in the wrist, followed by knee for 3 days. Joint pain was associated with redness and decreased mobility. He was treated in local GH, and the illness resolved completely after 7 days of antibiotics were given. 2 months ago, patient had low-grade intermittent fever for 1 week, which resolved on medication, and had history of coughing out clotted bloods early in the morning. After a few days, he started having frequent episodes of fever with breathlessness, which relieves on antibiotic medication. Not a known case of diabetes mellitus and hypertension, no history of tuberculosis or contact with TB, no history of asthma and thyroid disease, no history of previous surgery. Personal and family history, decreased appetite and normal sleep, normal bowel and bladder movements, no known addiction, family history not significant. Socioeconomic history, the family lives in a Pakka house, 3 members live in the house, 2 rooms and 2 windows, income 9,000 per month. According to modified BT Prasad classification, they belong to middle class. Summary, a 46-year-old male belonging to middle.
We'll just go back to the history initially. We'll discuss and then we'll come back to summary and analysis. Okay?
Sure, sir.
Yeah. Can you go back to the first slide?
Yes, sir.
So basically what I want to tell you people is, I think all of you will be well versed in all the possible questions and the causes. The main thing that you should learn how to actually go across a case, a cardiovascular case, is how you interpret the history and how you actually come to a hemodynamic analysis, and then how you go about examination. So you have to understand this. It is an art. History taking is an art. I think you would have heard all your professors, you would have read it in all the books. History taking is an art. It will take years to develop it. Nobody is still perfect. Maybe the most senior most professors will be perfect at it, but it is always a learning curve. Okay. So first you should understand each point has its weightage. Each point was developed many years ago by great physicians, and each point has its valid importance in coming to a diagnosis. Okay, so let's go across this. Patient details. I think you would have heard the general questions. I'll first start with what they might ask you in the exam. Then we'll go a little further, and I'll try to tell you people some more things that it might be a little more for at the MBBS level, but it will definitely make you get interested to read more. Okay, so first you tell me, what is the importance of age? This is a standard stereotypical question.
Sir, for age, there are diseases affecting different age groups. For example, rheumatic fever affects the younger age group between 5 years to 15 years. And when we tend toward older age, we are more likely to see degenerative and infectious conditions.
Okay. Anything else? Can you elaborate? This is you are, see, in your mind, you already know this is a probable rheumatic heart disease.
Yes,
First, when you approach a case, at least when you're starting presentation, you try to go broadly. Okay. First, you
yes.
start at the younger age. What are the possibilities at the younger age?
Congenital heart disease,
Good.
starting
Yeah. Congenital
congenital,
heart disease. Yeah. Tell me.
then associated infections.
Okay. Yeah. Tell. Keep going. Congenital
Start,
in first decade, second decade, third decade. What are the possibilities? Okay. See, in congenital heart disease, you might have a case. It's sometimes possible that you might have a TOF case for kept for the exam. It was kept for my exam when I was in UG. Usually, the stereotypical case that you will have is RHD. Okay, that can be kept as a long case or a short case. Okay, so
yes,
if it's kept as a long case, your history must be much more detailed. Okay, the history you have now is not very detailed, but we'll go across it and I'll tell you how to take it. Okay, so now
yes, sir.
first in congenital heart disease, you must understand how history will be. Some just a few points. I won't go widely across topic. This is mainly a rheumatic heart disease discussion. In congenital heart disease, you should understand a patient will have a longer history, and you should take in history mainly from the patient's relative, or mainly the mother or the father.
Yes,
Understood,
sir.
no? So
Yes, sir.
in congenital heart disease, there are two types of uh, broadly classified diseases: the cyanotic and acyanotic. Acyanotic also they might keep for you. It is rare. If they find a case, they might keep a very classical case. Acyanotic heart disease, can you give some examples?
Right to left shunt,
Acyanotic heart disease. Acyanotic will be left to right.
left to right shunts.
Yeah,
VST, AST,
yeah, PD.
PDA,
Okay. Okay, yeah. So now you have these three. Now, cyanotic heart disease, can you give some examples?
TAPVC,
More
TOF,
common. Yeah, top is
TOF.
more common. Then, okay. See, when you start off with this congenital heart disease is possible. It can be acyanotic or cyanotic. Acyanotic will be these three: ASD, VSD, PDA, and cyanotic will be these two: TOF, TIPVC, TGA, DORV, whatever you think. Okay. So
Yes,
that you tell for the congenital first decade. Then you come to second decade. Second decade, most common, what you told is rheumatic heart disease. Okay.
yes, sir. Yes, sir.
Now, rheumatic heart disease, rheumatic fever. It is the most common, especially in our country. Correct, no?
Yes,
Then
sir.
you have, then in third decade, what all possibilities can you have?
Complication of rheumatic fever.
Yeah, okay, correct. Rheumatic heart disease progression, worsening of lesions. Okay. Fourth decade, fifth decade,
Fifth decade, we have malignancies and degenerative conditions.
degenerative conditions. Okay, good. Degenerative conditions little more later. It is not usually in the fourth and fifth decade. Usually starts in the sixth and seventh decade. Fourth and fifth decade, you can usually put conditions such as worsening of rheumatic heart disease. They can develop multiple episodes of infective endocarditis.
Yes,
They
sir.
can also, if patients with risk factors, one more very common condition that can develop in the fourth and fifth or sixth decade is,
Atherosclerosis.
yes,
Atherosclerosis.
atherosclerosis. Good, ischemic heart disease. Okay, so
Yes,
now
sir.
you have a good answer for the question. What is the importance of age? You got it, no? You start
Yes,
off
sir.
first in childhood. Can be congenital heart disease. Can be acyanotic or cyanotic.
Yes, sir.
Acyanotic heart disease, you have these three. Cyanotic heart disease, you have few. Just give a few examples. Then you come to second decade. Then you come to fourth and fifth decade. Then you come to sixth and seventh decade. So you'll be very impressed. The examiner will be impressed at this first time on if they ask what is the importance of age. Okay.
Okay. Okay.
Now, what is the importance of gender?
Female genders are more predisposed to autoimmune diseases. Male
Good.
gender, male gender are more prone for accidents and infections.
Accidents unlikely, but you can tell atherosclerotic diseases at age group, at this particular age group, because you have 46-year-old, you have more common atherosclerotic diseases. Okay. They can have diabetes and hypertension. They can have atherosclerotic ischemic heart disease. Okay, just broadly. There are multiple other examples. I don't want to go into too much detail, but you should know how much to tell. At least 2-3 points you should know.
Yes.
Okay. Now, what about address?
Location nearer to hospital in case of emergencies.
Okay, more about
And
etiology.
etiology, like mountain areas and those things.
Tell. Give some examples in cardiovascular. Whatever you know, it's okay. Anyway, you're all learning. Have you heard? Okay. Have you heard of endomyocardial fibrosis?
Caused by measles.
No. Have you heard of it? Endomyocardial
No,
fibrosis?
sir, no.
Okay. Endomyocardial fibrosis is a classical condition which is very common in this belt, coastal belt of Kerala. It is also common in certain geographical conditions in locations in the world, like sub-Saharan Africa and also in South America. This is probably related to a geochemical hypothesis. I won't go into detail regarding that. Remember this condition, endomyocardial fibrosis. Okay, some more conditions.
Sukumar, you told high mountain areas. Which condition is more common in mountain high altitudes?
Yeah.
Thyroid diseases, sir.
Good.
No, in cardiac only.
In thyroid also you can tell. Hypothyroidism, you can tell. No problem.
Cardiomyopathy, sir. Yes, sir.
No, which common, you already mentioned, sir has already mentioned that condition. It's a congenital condition.
PDA.
Very good.
Good.
Like that. Okay.
PDA. Very good. Yeah, this is an important thing about geographical. Just give an idea how you go about evaluating the history and examination. You understood, no? So
Yes,
just
sir.
few examples you should know. You should be able to tell immediately, at least 2 to 3 you should be able to tell the examiner. Okay. Now
Yes.
come to presenting complaints. Yeah. Now what? Now just that you have these 3 complaints, can you tell what possible system is involved?
So breathlessness, if you look at first, we'll start with the RS, but breathlessness and cough will start comes under RS, and if we include palpitation, it comes under more likely towards CVS.
No, first you should understand that cough preceding breathlessness is most likely to be respiratory. Breathlessness preceding cough is most likely to be cardiovascular. It's not a hard and fast rule, just a way to remember this. Okay.
Yes, sir.
Cough preceding breathlessness is RS. Breathlessness preceding cough is cardiovascular. Okay. Now, can you give some examples where cough can precede breathlessness in cardiovascular diseases?
Pulmonary hypertension.
Okay, pulmonary hypertension, you will not have cough, but yeah, the one etiology of pulmonary hypertension, there are 5 different etiologies. One etiology, okay, thromboembolic. For example, if your patient
Pulmonary
has pulmonary thromboembolism, yeah, correct, that's good. Just keep trying, that's how you'll remember.
Pulmonary thrombosis.
Pulmonary embolism.
Thromboembolism.
Yeah, pulmonary thromboembolism, that's correct. So if you have multiple small emboli that go and lodge in the peripheral pulmonary arteries, that can cause pulmonary infarct, and that can cause pleuritis and cause cough much before the onset of breathlessness. Small infarcts, small emboli will not cause breathlessness, but multiple small emboli over a large time can cause thromboembolic pulmonary hypertension. That is our entity. Just to remember, that is not a hard and fast rule, but breathlessness preceding cough is most likely cardiovascular. You understand?
Yes, sir.
Okay. So now this patient, you are putting like your foot down and saying that's most likely to be cardiovascular. So you have to take your history in view of cardiovascular, but keep a broader view in other systems also being involved. Okay. Go to your HOP. History of presenting complaints. Yeah. Now see, in the HOPI, you have to take write the history in the patient's own words as much as possible.
Yes.
Okay. Now, patient's own words means it's better not to say words like patient was apparently asymptomatic. Okay. Patient will never say asymptomatic. Patient will never give technical or medical words. As much as possible, for example, in CNS history, you will be describing as much as possible in the patient's own words, right?
Yes, yes, sir.
Similarly, in a long case, for a cardiology long case, make sure you write the history in the patient's own words. So if the patient is apparently well 5 months ago, when he developed breathlessness is okay. It's better not to write dyspnea at this level. Okay.
Yes, sir.
Breathlessness was insidious. The onset and progression is correct, but when you're writing NYHA class 2 and NYHA grade 2 to grade 4, it's better to describe what functions or what activities the patient was doing at the time of onset of symptoms and how it's progressed over the last 3 months. Okay. This
Yes,
is basically a medical term. What grading we are giving is a medical term. It should come in your summary and analysis.
okay, okay.
Okay. It's better to write what activities the patient was doing at that time and how those activities has progressed. For example, if the patient was able to walk for about 30 minutes 3 months ago, and now he is not able to walk even 10 minutes. So it gives a good idea how the disease has progressed, how the
Yes, sir.
symptom has progressed. So you understand?
Previously, yes, previously the patient used to take up stairs.
Yeah.
He lives on a three building floor.
Okay.
So he used to take stairs. Now he's taking lift.
Yeah, so that
That's all.
you can refine that a little more. How many flights of stairs was he able to climb?
Yes, sir.
Okay, that you can write. How many flights of stairs? One flight of stairs is, no, there's one going up.
18. Oh,
Yeah,
yes.
two flights, like one flight of stairs. If he is able to, for example, if his house is on the third floor, if you give history like this, patient's house is on the third floor, he used to climb to the third floor, usually up before 3 months. Now he's not able to climb even one flight of stairs without feeling breathless. So that gives a good idea to the examiner that his disease has progressed significantly.
Yes, sir.
Okay. And currently, when he's come to the hospital, his condition is he's dyspneic or breathless at rest. Okay.
Yes, sir.
Yeah. There's some one comment in the chart saying is one's own awareness of breathing. Yes, this is actually breathlessness on exertion is actually a clinical cardiovascular symptom. If you think of breathlessness, the definition will be awareness on breathing. That is correct. But when you actually put it across in cardiovascular terms, you have to put it across first as breathlessness in exertion, which started insidiously because it can be either acute or insidious. Acute causes of breathlessness, can you tell me, Sukumar?
Pulmonary thromboembolism.
Okay.
Acute pulmonary edema.
Yeah. Then?
Left-sided outflow obstruction.
That is not acute. That will be more of a gradually progressive, insidious onset.
Asthma, severe asthma.
Okay, cardiovascular. Keep in cardiovascular. Acute MR, acute AR.
MR, yes.
Ventricular septal rupture in post MI. MI itself, MI is more common, it should come first. Okay, these are acute causes. So in this, for example, in this condition, you have to tell the patient had acute onset of breathlessness. You understood, no? So it gives a very clear impression to the examiner and finally to you when you are actually trying to diagnose the patient. You have to understand that this goes beyond the exams. What I'm trying to tell you is this is helpful for you even in the future. So once you find out what the onset is, understand the progression and what is the current condition. That is how you have to explain each symptom. Okay?
Okay.
Yeah, breathlessness increased on lying down and on exertion. Now, do you mean to say here he was orthopneic?
Yes, sir. On lying down, it increases more on exertion, sir. There was some level of breathlessness.
This breathlessness increasing lying down is a very hard symptom for cardiovascular disease. You have to be very sure and certain when you're describing it. Can you describe the breathlessness on lying down? When did it start and how did it progress and what is it at present?
Sir, like last 2 weeks ago, he had some fever, sir.
Okay.
Then he started developing breathlessness even on lying down. So he puts 2 pillows over in the bed and starts sleeping. Sir.
Okay. So you want to say because he had developed fever, then he developed breathlessness.
Yes, sir. After that, and it's still he's like that only.
So it's better to put the, I mean, when you're describing breathlessness, you should, better to say that patient had an episode of fever, describe the fever, and he developed breathlessness at that point. Was it an acute event that time?
More likely insidious, but aggravated.
Okay, see, now, thing is, this is very important because what am I thinking of? What possibility is possible when you're saying this fever and acute onset of breathlessness? Infective endocarditis.
Yes, sir.
You understood, no? Infective endocarditis that can cause acute MO. So that's why this is very important. This particular aspect of your history is very important. So
Sir,
you have
but
to know.
breathlessness was progressing over 3 months. Sir. Last 2 weeks he had a severe breathlessness.
No, that is okay. But you told me the breathlessness started after the episode of fever.
Yes, sir. But it was not so severe. He took only 1 day fever. Sir.
Okay. Okay. So he had only 1 day fever and then breathlessness started progressing from then. He did not have an acute worsening of breathlessness.
No.
Okay. Now that is clear. Now breathlessness is increased on lying down. What do you mean? That is orthopnic and that is present now, or was it there at that time?
It is present now. Over the past 2 weeks, it's present now. Sir.
Over 2 weeks. Okay. So that means orthopnea was present only recently.
Yes, sir.
So you should understand orthopnea is a more severe symptom of cardiovascular disease, and that is more likely to be at a recent point of time to when the patient presents to the hospital. So if you're having orthopnea from that point of time, that from the onset of symptoms, that means his symptoms were significantly severe at that point of time. So that's how you understand the severity of breathlessness. Understood?
Okay.
Okay. Now the patient also had complaints of nighttime awakenings in the last 3 months. You mean to say this is
PND?
PND. Now, how do you describe PND? There's a better way of writing it in history. I just want to tell you.
The patient, after going for sleep, after 2 hours, he will start feeling air hunger. Then he walks a little bit or keeps his legs dangling at the side of the bed to relieve breathlessness, and then afterwards he sleeps comfortably.
Yeah. So you can describe that in the history. Describe that patient had episodes of nighttime disruption of sleep, after which he needed to stand or sit up in the bed, and it would reduce slowly. You can actually describe the whole symptom. That will be a good point in your history. Okay.
Okay. Okay.
Then it will decrease in sitting and it is associated with use of accessory muscle. Don't use technical terms. Okay.
Okay. Okay. Okay.
Don't use technical terms. Then no seasonal variations were noted. Okay. You mean to say in breathlessness in a general sense, no seasonal variations. You want to rule out
asthma.
Yeah, respiratory conditions. Okay. Daily activities were affected from the last 2 weeks. May again mention what activities were affected. It is more, see, for example, if you have a long case, it's better to write it like this, like how I told. The more descriptive you are, the better it is. It is better for you to understand what's happening to the patient. It is also better from an exam point of view. That shows that you have a clear understanding of the history. Okay?
Yes, sir.
So you understood this, no? Go to the next slide. Now palpitations. Now palpitations were exertional and irregular. Now what are you thinking of when you say this 2 words? Wait, 1 minute. Before that, there's someone asking, how do you differentiate PND and orthopnea? Can you tell that?
Sir, orthopnea is a severe symptom. It develops lately after PND. If orthopnea is present, PND won't be present. Orthopnea is the patient feeling breathlessness as soon as the patient lies down in the bed.
Yeah, correct.
And PND, it develops after 1 or 2 hours because of the venous rhythm and the sympathetic drive.
Yes, the sympathetic drive will reduce during sleep. That causes an increase in venous return, pulmonary congestion, and worsening of left heart failure. So both PND and orthopnea is a very hard symptom for left heart failure. You should understand PND is categorized as a NYHA grade 3 symptom. Orthopnea is characterized as a NYHA grade 4 symptom. Understood, no? So orthopnea is a more severe symptom compared to PND.
Yes, sir.
You understood. Okay. Now, palpitations. Now, palpitations is a very important topic, and it is by itself a huge topic in cardiology. We'll try to cover it as much as possible. Now, palpitations are exertion irregular. What do you think? What do you mean by that statement?
Whenever the patient walks or when accompanied by breathlessness, he feels the presence of palpitation, and the rhythm of the heart is irregular during those palpitations.
Okay, whenever the patient exerts himself, he's feeling palpitations. But you're saying it's irregular. Okay.
Yes, sir.
You see, usually when palpitations occur during exertion, they're most likely to be regular. Okay. For palpitations to occur during exertion and being irregular, what do you think the possible condition is?
Atrial fibrillation.
Yeah, atrial fibrillation. Correct. That patient is having paroxysmal episodes of atrial fibrillation, and that during those episodes of exertion, this atrial fibrillation is worsening and he's developing palpitations. Yeah, no? So in your examination, you should be clear that you find this possible atrial fibrillation. And also in a history, that's important because you have to ask some few extra things in history. What else will you ask when you have this particular point when you get in the HOPI?
Clots related to clots like symptoms of seizures, syncope, headache.
Good. Yeah, that you have to ask because patient can have thromboembolic episodes. Okay. It is also important to know when this palpitations exactly started. Did it start during when his breathlessness worsened, or did it start after the onset of breathlessness after a few weeks later? That is also important. Why is that important?
Breathlessness followed by palpitation is due to valvular heart disease, and other might be due to arrhythmias.
No, see, you have to understand atrial fibrillation can cause an exacerbation of the underlying condition, especially if the patient has reduced cardiac function. Okay, remember that. If the patient has reduced cardiac function, the atrial kick, what you know as the atrial kick, atrial systole, contributes to 25% of the cardiac output. Okay, if that is lost, patient's cardiac output decreases by 25% and he feels more breathless. They can actually go into failure whenever atrial fibrillation develops, these paroxysmal episodes. That is one possibility. Now, one more possibility is when you say palpitations are exertional, one thing is they can be a volume overload condition of the heart. Okay?
Yes, sir.
Volume overload conditions, can you just give some examples?
Mitral regurgitation, aortic regurgitation.
Good. Yeah, these are volume overload conditions. So when you get exertional palpitations, this should be what this should click in your mind. Now the patient is having exertional and irregular, so you should possibly think that the patient is having a volume overload condition and is having paroxysmal episodes of atrial fibrillation.
Okay.
Now atrial fibrillation is also important. Why? In cardiovascular disease?
In management, we have to add warfarin.
Before management. It means the disease has progressed significantly. That means there is significant left atrial dilatation causing atrial fibrillation. It is a very good point to say when to understand. Okay. So now it is noted along with breathlessness on last two months. You told it is exertional. So we're coming to possibility of volume overload condition and possible paroxysmal episodes of atrial fibrillation. It was associated with sweating and sometimes felt during sleep. What do you think this is?
Palpitation may be felt during sleep.
Associated sweating, that means there's a decrease in possible cardiac output at this stage. Okay, one of the main causes of decreased symptoms of decreased cardiac output are these conditions: the sweating, fatigue. Patients have all these conditions. That means possibility of a decreased cardiac function is there. You understood, no?
Yes, sir.
Patients having palpitations during sleep, again, you can explain by paroxysmal episodes of atrial fibrillation.
Yes, sir.
So every line in your history, we can come to a possible understanding of what the patient has. Understood, no?
Yes.
Okay, now next you come to cough. Cough started 3 weeks back. It was progressive, whitish, non-foul smelling sputum and not bloodstained. Okay, you have described the sputum and you have described the cough, increase, aggravated on lying down, no dilation. So you want to attribute the cough to?
Cardiac cause.
Cardiac cause, how?
Pulmonary congestion causing dry cough.
Pulmonary congestion. Okay. Pulmonary congestion can cause dry cough. Now, yeah, that is correct. That you can tell pulmonary venous hypertension causing dry cough. Now, these patients can also develop pulmonary edema, and that can lead to wet cough. That you know. So,
Yes,
if the patient that you should also ask when patient had any episodes of pink frothy sputum. That is classical. Not everyone will have, but it's also a good point to add in your history. You understand, no? Okay. Now, cough has increased in frequency and limits the activity of patient. This is good. You told the progression of cough, and you're told at present it is limiting the activity of patient. Make sure you describe the activity. You can explain everything in one shot. Okay.
Okay.
Now you understood. There is progressively worsening breathlessness. Okay. There is
Yes,
PND. There is orthopnea recently. So you have dyspnea, PND, orthopnea, exertional palpitations, irregular palpitations, and cough. Okay, now you go to the next slide. Now, negative history. Now, how do you write negative history? See, your negative history is not in a proper order. So, how do you think negative history should be?
First, pointing towards diagnosis, negative, ruling out the other possibility of diagnosis, then complication related to diagnosis.
No, see, it's like this. First, you have to rule out the other cardinal symptoms of the system you are examining.
Okay.
You understood, no? The other
Yes.
possible symptoms, the cardinal symptoms of the, what are the cardinal symptoms of the cardiovascular system?
Chest pain, dyspnea, palpitation, syncope,
Then,
breathlessness.
yeah, then cyanosis. Okay. Okay. So these are cardinal symptoms. You have to mention one line of no other these cardinal symptoms, whether it's present or not. Then you go to complications of CVS, other system involvement. Okay. Then you talk about infective endocarditis. How you rule out fever? No history of fever that you mentioned. Okay. No
Yes,
history of fever. Then no history of reduced urine output.
yes,
Why?
oliguria, hypovolemia causing oliguria, left-sided cardiac output is decreased, causing renal
Okay.
hypoperfusion.
Yeah, prerenal failure. Then one more possibility. You have one condition.
Infective endocarditis,
Yes, thromboembolic. Then atrial fibrillation, thromboembolic. So you have decreased urine output. Then what other complications can have? Hepatic.
jaundice,
Yeah. Why?
congestion, pulmonary congestion, backflow, and cardiac cirrhosis.
Yeah, correct. You can have that. You can have congestive cardiac failure and cardiac cirrhosis. Then abdominal symptoms also, you can tell abdominal distension also.
Okay.
Okay. Then CNS.
Syncope, headache, seizure.
Yeah, syncope, headache, weakness of limbs. Basically, if you want to rule out thromboembolic episodes of the CNS.
Yes, sir.
You understood that, no? So this one line will be no history of other cardinal symptoms. One line will be is no history of these complications, and then you come to other possible etiologies that you want to rule out. If you want to think, if you think this rheumatic heart disease is important, and then you have to ask one possibility of any acute exacerbations of rheumatic fever. Okay, that you should ask here. Okay, that you understood, no?
Yes, sir.
Yeah. Then this is how you write negative history.
Sure.
Okay. Make sure you put all the complications of the thing second line. In that you go system by system: pulmonary, renal, GI, and CNS. Okay,
Yes,
in
sir.
pulmonary you already mentioned. You mentioned hemoptysis already. Patient had hemoptysis. What else you can have pulmonary symptoms in cardiovascular disease? Pulmonary conditions at least.
Pulmonary artery hypertension, edema.
Okay, pulmonary hypertension that you're telling post capillary because of cardiac symptom only.
Cardiac.
Good. Then one more thing is
embolus from
They can have
atrial.
pleural effusion. Pleural effusion can also be there. The effusion is a very strong possibility in these patients. One more thing is, if they have right-sided infected endocarditis, what can they develop?
Pulmonary infarction.
Yeah. Pulmonary infarction, actually, infective endocarditis of right side, they can cause infarct, they can cause lung abscess, all infective conditions of the lung they can cause. Okay.
Yes.
So you should understand that this is how we write negative history. You rule out other cardinal symptoms, rule out other complications of the cardiovascular system, then you come to other systems and rule out the complications involved in those systems. And then you come
Yes,
to
sir.
etiology, mention a line in other etiologies that you want to rule out. Okay.
Okay.
Understood. So, and the end of history, we have that we have an idea that the patient is having a left heart disease, correct?
Yes, sir.
Probably a valvular lesion
Yes, sir.
with possible paroxysmal episodes of AF. And the valvular lesion is most likely regurgitant.
Mm.
Okay, so you got this much from history just by simple
Yes.
analysis. You understood now how to analyze history.
Yes, sir.
It's very simple. It's just applying what you have read into what the patient is saying. Okay. Now
Yes,
you
sir.
go to past history and we'll go to analysis.
Past history, when the patient was 16 years, there was an episode of low-grade fever with severe joint pain in the wrist, followed by knee for 3 days. The joint pain was associated with the redness and decreased mobility. He was treated in local GH and illness resolved completely after 7 days of antibiotics.
See here, when you want to basically say he had rheumatic fever at that time, so
Yes, sir.
you have to explain a little more. Was it migratory polyarthritis?
Yes, sir.
That is a catchy. That's the most important symptom in rheumatic fever. No, so you
Yes,
tell
sir.
it was wrist resolved for then followed by involvement of knee.
Okay.
That is migratory polyarthritis.
Okay.
Okay. Then the joint pain is redness and decrease. Okay, meant arthritis is there. He went to local GH. Illness was resolved. Then was he given any prophylaxis?
And the patient does not know, sir. Like he's
Now, how will you ask? Definitely, these people will know. You should ask: did you get any
injection.
monthly
Injection.
injections, or were you taking tablets every day? Okay, that should be given. There's his patient not giving any history suggestive of any monthly injections suggest for prophylaxis of rheumatic fever. That you can write. That is
Okay.
if you get that history, it's a very strong pointer towards your etiology.
Okay.
Okay.
But the patient does not know whether he is taking.
He doesn't remember.
He took prophylaxis. Yes, sir.
He does not remember. Okay,
Yes, sir.
that is fine. Anyway, this history points towards rheumatic fever, but describe the polyarthritis a little more.
Okay.
Migratory poly. Basically, you want to tell that he had migratory polyarthritis. Okay. Then
Okay.
2 months ago, patient had low-grade intermittent fever. Yeah, this is the thing what you told. No, he had an episode of possible pneumonia, and then he had worsening.
Yes. Yes, sir.
Okay. Now, you want to. How would you want to analyze this part of past history?
There may be some added infection which might worsen the already presenting cardiac condition.
Okay, you want to say that, or you can also say patient is having regurgitation, pulmonary venous hypertension,
And superadded. Yes, sir.
superadded infection. That is also one way. One more way is patient is basically these patients, these cardiovascular disease patients, will have what condition cardiac cachexia is, no?
Yes, sir.
Cardiac cachexia, low cardiac output state for a prolonged period will cause loss of weight, loss of appetite, and patient will have worsening, increased weight loss, and these patients will be immunodeficient. It's a relative immunodeficiency, and they're more prone for infections. Okay.
Oh.
Yeah. So this patient had pneumonia. So you're telling it's a possible LRT, secondary to the cardiac disease itself, and this. Hello.
This might have worsened the.
This might have worsened his condition and led to possibly a development of atrial fibrillation, that is having paroxysmal episodes, and that has caused worsening of his underlying condition. That is one possibility. Or the patient developed infective endocarditis worsening of regurgitation or valvular lesion and develop more symptoms that you should keep in mind. Okay. Now you're telling he had fever for 1 week.
He had low-grade intermittent fever.
Yeah, subacute infective endocarditis does not mean the patient can have fever with chills. Does not mean it will be like high-grade fever. The patient will be. We've seen patients for even 1 year. They'll have low-grade intermittent fever, low-grade, and when evaluated, only when an echo is done, you will find large vegetations on the valves. So, infective endocarditis, one very important thing to always keep in mind. Okay, it should not be missed out because it's a very treatable condition. Understood, no?
Yes, sir.
Now, do you know what treatment he received at that time? Any idea?
No, sir. He took He said he took antibiotics and it was resolved.
Okay.
For a week.
Okay. So this is past history importance. You understood, no?
Yes, sir.
Now, past history also mentioned this is okay, but also mention if you had any previous surgeries.
Yes, sir.
Okay. Any other previous admissions to the hospital other than this previously in the past, anything like that also mention. Okay.
Okay.
Now, history of diabetes mellitus and hypertension. This patient, this actually some examiners would like to have diabetes mellitus and hypertension in the present history.
Personally. Okay.
Present history, because it's an important thing if it's there. Okay.
Yes,
So
sir.
if it's there, mention it in the HOPI. If it's not present, okay, you can mention in the past history. Tuberculosis or contact with TB. Why is this important?
Pulmonary cause of breathlessness.
Then now you have some
relatively immunodeficiency state.
Okay.
So
how is it related to cardiology? I mean, cardiovascular disease in heart disease. How can it affect? It's a clue.
Myocarditis.
No, tuberculosis can cause pericarditis, constrictive pericarditis.
Yes, sir.
Okay. Constrictive pericarditis can cause predominantly right heart failure. You should understand. Predominantly right heart failure. And the cardinal symptoms of right heart failure is?
Bilateral bivascular crepitations.
No, right heart failure.
Elevated JVP and tender hepatomegaly followed by pitting pedal edema.
Yeah, that is right heart failure. Now, can right heart failure also cause dyspnea?
Due to ascites, it may cause.
Okay, that is an indirect way. Can it directly cause? There are some specific phenomena that is present. It is little complicated. If you are interested, you can read up. It will be little outside the purview of this presentation, but it can cause right heart failure. There are multiple mechanisms that explain how it causes dyspnea. Okay, right heart failure will not cause. One person is asking it can cause pulmonary edema. It doesn't cause pulmonary edema. Right heart failure can cause pleural effusions because of increased venous pressure. Okay, and that can cause pleural effusions. They can cause pericardial effusions. There's also an effect called the reverse Bernheim effect, where the increased pressure within the RV can cause the septal shift into the LV, leading to increased LV pressures. That is called reverse Bernheim. It will be a little complicated, but just if you're interested, you can read up about it. There are multiple causes. Okay.
Yes.
Next, no history of asthma or thyroid disease. Thyroid disease is important, especially because in this patient you have. Why is it important in this patient?
Cardiomyopathy, dilated cardiomyopathy.
No, more common. What happens? Thyroid disease.
Weight loss and so.
Hyperthyroidism. Okay, I'll give you a clue. Hyperthyroidism. What does it happen? What happens with hyperthyroidism?
High output cardiac failure.
Yes, correct. Good. High output cardiac failure is a very important thing that is very easily treatable due to hyperthyroidism. Okay. Yes. What happens with hypothyroidism? How does it affect the heart?
Not sure.
Hypothyroidism can cause pericardial effusion. Okay, it can cause pericardial effusion that can lead to significant dyspnea. It's not an acute pericardial effusion. It will be slowly collecting, and it can be actually quite massive and sometimes, and then patient can be severely dyspneic and tachypneic. Okay.
Okay.
Now, no history of previous surgeries. Previous surgeries, you want to specify, is it a general term saying that multiple abdominal surgeries, or do you want to specify
Both
something?
generalized. There was no previous surgery.
Okay. Okay, that's fine. Okay, next. Family history and personal history. Usually there's not many questions in this. Family history is important in this case. Okay.
Yes,
Family history is more important. When you come to differentials, I'll explain. But it's nice not to write that family history is not significant, because every patient will have some family history. Try to elaborate. Okay.
Okay, sir. Okay.
Try to elaborate patient how many, if he's married, how many children, his parents. Try to draw a family tree. It'll just take 2-3 minutes. Okay. You practice that. Draw a family tree and then ask them specific things in cardiology. What will you ask?
Previous history of sudden cardiac death in their
correct. That's very good. Why is that important?
Prone for like arrhythmias and dilated cardiomyopathies runs in.
Yeah, when you think of these symptoms and when you come to differential, we will discuss why family history of sudden cardiac death is important. And anything else you want to ask?
Atherosclerosis.
Atherosclerosis, good. If any family history of ischemic heart disease. You should always remember, though you have a history of rheumatic fever, in this age group, one of the most common causes of dyspnea and heart failure is ischemic heart disease. Okay?
Okay.
Though you have a history saying that patient is probably having rheumatic fever, you should always keep in mind that patient can have ischemic heart disease also. It is the most common. Okay?
Yes, sir.
Yeah. So family history, try to elaborate a little more. And usually that comes before personal history. It depends on examiner to examiner, but yeah. And then a decreased appetite and normal sleep. You told sleep was disturbed.
No, sir, he could feel the palpitations.
Okay. No, you said PND was there, some episodes of PND. Those are disturbed sleep only, you know? Okay. Yes. Anyway, it's not that important, but just try to keep your history like in one piece. Then normal bowel and bladder habits. Okay, that is fine. Usually there's not much questions on this part, but they can ask how can cardiac disease cause disturbances in appetite or bowel or bladder.
Cardiac cachexia.
Cardiac cachexia.
Reduced TNF levels, reduced
increased tumor.
Increased TNF.
That can cause decreased appetite and loss of weight. Yeah. Then how can it cause, one more way of how cardiac disease can cause decreased appetite? Anemia. Okay, infective endocarditis, anemia. Okay, that is in subacute infective endocarditis. Then one more. Yeah, one person has mentioned congestive gastropathy. Congestive gastropathy, portal gastropathy, yeah, same thing. Congestive gastropathy is an important cause how cardiovascular disease can affect the GA. Okay, just have that in mind. Okay, now that's done with family history and personal history. Now come to a summary. That's it. Oh, socioeconomic history. Yeah. Okay, this is fine. They might ask you why is socioeconomic status important in this case.
Previous history of acute rheumatic fever, it may be more prevalent in low socioeconomic status.
Yeah.
Overcrowding.
Yeah, that's the usual answer. That's enough, I think. They won't usually ask much more than this. There are some other conditions that socioeconomic history is important. One more thing is how you treat the patient finally. For example, if we'll come to treatment, that time we'll discuss. Okay.
Okay.
Next summary. Tell.
A 46-year-old male belonging to middle class, according to modified B.G. Prasad classification, presented with complaints of progressive breathlessness and orthopnea. He also had a history of irregular palpitation and progressive non-productive cough worsening in past 2 weeks. No history of fever, chest pain, syncope, or hemoptysis.
Yeah, this is a fairly okay summary. You have mentioned all the important things. You have not mentioned he had exertional palpitations, which is a very important point. Okay.
Okay.
Expressional palpitations is also important because that is one of the ways how you localize what type of lesion the valve has. Okay.
Okay.
See, in your mind, you've already made up that it's probably rheumatic heart disease. Okay. Now, how do you come to differentials? See, this is a way how you come to differentials. You understand? Let me tell you. How you find out is you divide the heart into three parts. This I have learnt it during my MD time, but it will help anyone. But divide the heart into three parts: myocardial, pericardial, and valvular. Okay.
Okay.
Valvular, you already told, rheumatic heart disease. It explains all the symptoms. How you find a differential diagnosis. First, you should find all the symptoms should correlate to some particular condition. That's how you get a differential. Now, rheumatic heart disease, it clearly fits into every symptom that you put across. Okay. Patient has dyspnea, patient has orthopnea, PND. Okay, so you have a left heart involved. So you narrowed it down to the left heart. Now patient has exertional palpitations. You narrowed it down to a regurgitant lesion. Okay, because dyspnea started before palpitations, you narrowed it down to most likely being the mitral valve. So now you know it's a mitral regurgitant lesion. Okay.
Yes, sir.
Now you have exertional and irregular palpitations. Now you know that it is most likely paroxysmal atrial fibrillation. There is no other condition that causes irregular palpitations. Remember, when you say irregular palpitations, you're basically committing to atrial fibrillation.
Yes, sir.
Okay. If you don't find it during an examination, don't be scared. You can always tell it is paroxysmal episodes. It was not there at present. Okay. You should remember that. Now you localize it to left heart, mitral valve, regurgitant lesion, possibly with atrial fibrillation. Okay.
Yes, sir.
Now with the history of fever in the last 1 month, lasting a week, you should always keep in mind possibility of infective endocarditis. Okay, you should never leave out infective. That's why even in your diagnosis, you always write no signs of infective endocarditis. That has been passed on from generation to generation so that no one forgets this thing called infective endocarditis. Okay.
Yes, sir.
So that's always a differential, especially when you have patients who had history of fever and worsening of symptoms after that. So this you have come to, this is how you localize, this is how you try to localize what the lesion is. Now your first differential will be rheumatic heart disease, most likely mitral valve involvement, most likely mitral regurgitation. Okay, that is your first differential. Your second differential, what do you want to keep?
Infective endocarditis.
Yeah, good. Second one is infective endocarditis of the mitral valve causing worsening mitral regurgitation. Okay, but that, how will you defend that? See, each differential when you give, you have to always defend it. Your first differential is this because of these reasons. Your second differential is this because of this reason. And why it's not the first is because of patient is not having an acute symptoms. Okay,
Yes,
you understood, no? So that's the second differential. What is the third differential? What do you want to keep? Degenerative valve. Example?
Mitral myxoma of mitral valve.
Myxomatous mitral
degeneration of mitral.
Leading to?
Mitral regurgitant lesion.
Mitral valve prolapse. Mitral valve
prolapse.
Okay, mitral valve prolapse is the pathological entity that is second most common. Valvular disease. Actually, all the natural history studies on valve regurgitation, most of them are due second because of mitral valve prolapse. Because in the Western countries, the rheumatic heart disease has come down to almost zero. So most of the studies are because of mitral valve prolapse. Okay, so this is an important thing. And on this patient, why does he have a recent worsening? What you want to say?
Increased exertion in infection.
Infective endocarditis again. Mitral valve prolapse also patients have an increased risk of infective endocarditis. Now you have history of fever. All your symptoms are pointing out to regurgitation. Now you have degeneration and possible infective endocarditis. That's why the patient is having worsening of symptoms now. Now, why is it not your first differential? What do you want to say?
Because the patient had a past history of rheumatic fever.
Good, very good, very good. That is the correct answer. You first have to tell patient has significant history of rheumatic fever in the past. So that's why I want to keep a rheumatic valve disease first. Okay. Now you finished. Now that's good. You finished valve. Now come to myocardial. Myocardial, what all you want to give?
Dilated cardiomyopathy.
Before that, a more common one.
MI causing
MI. Good. Ischemic
papillary dysfunction.
Good. Very good. Ischemic heart disease. Ischemic heart disease that is causing MR.
Papillary dysfunction.
That is a very good answer, because ischemic heart disease basically I'll just give you a small 2 points. There are two papillary muscles, anterolateral papillary muscle and the posteromedial papillary muscle. If the left coronary is involved, anterolateral papillary muscle can be involved. So you'll have my MR jet, which is posteriorly directed. Okay. If the right coronary is involved, you'll have sometimes involved the posteromedial papillary muscle. So you'll have an anteriorly directed MR jet. Okay.
Okay.
So in these patients also, you can have ischemic heart disease causing papillary muscle dysfunction and worsening MR. It doesn't have to be acute. Okay.
Yes,
it doesn't have to be acute. If it's acute, what do you think of?
Acute MI causing papillary rupture or cauda rupture.
Good. Papillary muscle rupture. That is correct. Okay.
Yes, sir.
So that is ischemic heart disease. Second, then after myocardial, what else will you think of?
Dilated cardiomyopathy.
Good. Dilated cardiomyopathy. Dilated cardiomyopathy can occur in this age group also. It is usually little earlier, but it depends on which gene is involved. Sometimes idiopathic dilated cardiomyopathy can occur at different ages. Sometimes they can have post-myocarditis also. Post-myocarditis, patient had history of fever. Okay. Probably a bacterial infection after that. If it was a viral infection leading to a bacterial infection and that viral infection caused a worsening of his LV function, that is post-myocarditis sequelae, if his LV function is not improved and MR is worsened. Okay, dilated cardiomyopathy.
Sir, I didn't follow.
Okay, for example, myocarditis requires certain etiologies. What are the etiologies of myocarditis?
Viral, bacterial.
Yeah, good. Viral. Most common is viral. Okay. If the patient had a viral infection that caused myocarditis, okay, viral infection usually will be a respiratory tract infection that usually affects the heart also because of autoimmune mediated damage. Okay.
Yes, sir. Yes, sir.
There's also direct viral damage, but that is less common. Now, then you have, then if the patient had secondary bacterial infection at that time, it could have masqueraded as a pneumonia and that he was treated. If the echo, if for example, he was not examined properly at that time in the outside hospital, and if an echo was not done at that time, maybe they would missed out LV dysfunction.
Yes, sir.
Okay. Now that would have persisted, and patient will have dilated cardiomyopathy now. That is called post-myocarditis dilated cardiomyopathy.
Okay.
Okay.
Yes, sir. Yes, sir.
That, no? So in this patient, the dilated cardiomyopathy can cause worsening dyspnea, worsening increased LV dimension can cause increased annular dimension leading to central secondary MR. Understood?
Yes, sir.
And that can cause worsening of left atrial dimensions and atrial fibrillation. It can explain all your findings.
Yes.
Okay. Now again, you will tell rheumatic is still first because he has past history of rheumatic fever. That's why rheumatic fever history is so important. You understood, no?
Yes, sir.
Okay. Now pericardial. In myocardial, there are multiple other things, but I'll just keep it limited for now. Pericardial. Yeah.
Constrictive pericarditis.
Constrictive pericarditis, good. Now constrictive pericarditis, because we thought of possibility of TB and all that, but that is less likely because patient has no. That's why you want to keep it as a last differential.
Yes, sir.
Okay. Now for MBBS exam, you can keep 3 to 4 differentials. That is enough. I just told all this so that you have a full understanding of the topic.
Yes, sir.
Okay, you understood, no? So till now you understood fully history, how you localized, how we came here, what are the possible differentials. Now in examination, you will know what all to search for.
Yes, sir.
You understood? Okay. Okay. Yeah. When somebody is asking, can congenital heart disease be a differential? Very good. Can you give some examples? Sukumar.
Sir, congenital heart disease usually present in first year of life.
Yeah. Okay. Which are the congenital heart diseases that present in the fourth or fifth decade?
Cardiomyopathies,
Very good. Some people have written ASD.
Naxos syndrome.
ASD. No, tell common things first, Sukumar. See, whenever you tell, no, tell common things first. ASD is a very common asymptomatic congenital heart disease that presents at um, this particular age group. Why? Okay, it will be a little complicated if I start explaining why that happens. But you should understand that ASD is one of the things because you know what Eisenmenger syndrome is.
Yes, sir.
Okay, Eisenmenger.
Conversion of
Yeah, a left to right shunt to a right to left shunt, reverse left shunt basically. And ASD will usually take a longer time. Why that happens is a very multiple mechanisms, multiple reasons are there that you can read up, but ASD is one of them. Then other congenital heart diseases, this will be a little complicated, but since people are asking, I will tell. Other adult congenital conditions that can present at this age.
idiopathic pulmonary hypertension.
Okay, you want to say that will won't present in a fifth decade, no? Fourth to fifth decade, usually present in the second decade, second or third decade. That is not a congenital condition, that is more of a genetic, idiopathic, no? The thing is, it's bone morphogenic protein, all those things, let's leave that out, it'll be too complicated. Now, congenital conditions, if anyone knows, can you tell? PDA at this age is unlikely. HOCM is not a congenital condition and doesn't, you will not have these particular features, whatever we got in the history. Then anything else? I'm seeing the chat group and telling us. Okay, okay. This is, it might be a little too much for you, but I will tell you. Congenitally corrected transposition of great arteries. Have you heard of this condition?
Yes, sir.
A congenitally corrected transposition of great arteries. This can be missed at small age, at when they are young. When they're young, this can be missed completely, and it is known that these patients develop left ventricular dysfunction in the fourth, fifth, sixth decade.
Okay.
You should remember this congenitally corrected transposition of great arteries. One more condition, if you want to know, I will tell you. Anyone? Very good. Someone has told Epstein's anomaly. Very good. Pallavi T. She has told Epstein, adult Epstein's. 10% of Epstein's anomaly will be unrecognized in childhood and present in adult life. Cyanosis need not be present. Okay.
Okay.
Adult Epstein's, it can also present. They can also have symptoms of left ventricular dysfunction because they have noted that Epstein's anomaly can have myocardial dysfunction. That is again very complicated, but just remember this. So you understood all the differentials.
Yes, sir.
Okay. Now we'll go to exam. So you see, when you come to end of history, come to differentials. Now you have to make a plan for examination. Okay.
Yes, sir.
Now you should have in your mind, your first differential is rheumatic. So you will be thinking of possible things that you'll see in rheumatic. Then you will be thinking of possibilities of infective endocarditis. Don't miss out features suggestive of infective endocarditis. Okay, when you come to auscultation, make sure you search for mitral valve prolapse.
Yes, sir.
Then myocardial diseases, you want to be sure that it's not a dilated cardiomyopathy. Then you will make sure the apex is not displaced significantly. See if S3 is there. All those things are there that points towards features of dilated cardiomyopathy. Okay, all these things you keep in mind when you go to examination. That's what you should do at end of history. Basically, your diagnosis will almost be done at end of history. Have you noticed?
Yes, sir. Like,
Yeah,
except for localization, many things.
Yeah, everything you can do at the end of history. If you take a proper, clear history and analyze it clearly, you will come to your diagnosis. One more level up when you go, for example, in your MD or more beyond that, there's something called hemodynamic analysis of the history. Do we have enough time? I don't know. It's already 7 o'clock. We have to go into examination also. See, hemodynamic analysis of history.
Yes, sir.
You have, for example, you know that patient is having dyspnea. Now, how will you explain dyspnea hemodynamically?
Pulmonary congestion.
Good. Pulmonary venous hypertension. That is the cause for dyspnea, orthopnea, PND. Okay.
Yes, sir.
Now, palpitations, exertional palpitations. Hemodynamically, the cause is volume overload.
Volume overload.
Good. Irregular rhythm. That is again due to atrial fibrillation.
Conduction.
Okay. Now,
Yes,
this is called hemodynamic analysis of the history. This again gives a clear understanding of what possible lesions the patient has and how it's affecting him. Okay, so keep this in mind before we go into examination. Okay, we'll go into examination. Go.
General examination. The patient was conscious, oriented to time, place, and person, moderately built and nourished. The patient had mild pallor, no icterus, no cyanosis, grade 2 clubbing was present, no generalized lymphadenopathy, bilateral pitting pedal edema, and no spinal anomalies.
Now you complete the full examination, then we'll come to each point.
Okay. Vitals. The patient was afebrile, pulse 110 beats per minute, regular rhythm, normal volume, normal character, no radiofemoral delay, and no vessel wall thickening. All peripheral pulses were felt. Blood pressure 115/86 millimeters of mercury in right arm in sitting position. Respiratory rate 17 per minute, abdominothoracic type. JVP 7 cm elevated above the sternal angle. Inspection. Trachea appears in midline, chest wall symmetrical, presence of precordial bulge, apex beat seen in left 6 intercostal space, medial to midclavicular line. No other visible pulsation seen, no dilated veins, no scars and sinuses. Palpation. Inspectory findings were confirmed in palpation. Trachea is in midline, apex beat is hyperdynamic, felt in 6th intercostal space on the midclavicular line. Parasternal heave of grade 4 on left side is felt. Palpable systolic thrill is present. Palpable P2. Epigastric pulsation hitting the tip of the index finger is noted. Auscultation. Mitral area, soft S1 is heard. Tricuspid area, S1 and soft S2 is heard. Aortic area, S1 and loud S2 is heard. Pulmonary area, loud P2 is heard. Murmur. A pansystolic murmur of grade 4 with soft S1 and loud S2, best heard in mitral area in left lateral position with breath held in expiration, radiating to left axilla and back with no variation in respiration is heard using diaphragm of the stethoscope. The murmur also increases on recumbent position and decreases on standing.
Okay, you go back to the first one. Yeah. Okay. See, some discordant findings are there in your general examination. We'll discuss each point. Okay. Okay. Patient conscious oriented time, place, in person. That is the usual thing. Moderately built and nourished. Usually mention BMI also. Okay, if possible. BMI also, and make sure you check temperature in your exam. These are all the usual things that they will see. Okay. Patient has mild pallor. Okay, I'm not exactly discussing all the multiple causes of each thing, and I'm just trying to make you analyze so that you can apply it in the future. Okay.
Yes.
Now, mild pallor is there. Okay, that is one of your positive findings. Then you have grade 2 clubbing. These are all important.
Pitting pedal bilateral.
Pitting pedal edema is there.
Yes.
Okay. Anything else you want to tell in general examination? Something you're missing out? We'll go to the next slide. 1 minute. Next slide. No, go back. You missed out one important thing in the general examination. You should always mention signs of infective endocarditis, peripheral signs of infective endocarditis.
Okay.
That should always be mentioned. Okay, that is one important part of the general examination. What are the peripheral signs of infective endocarditis? The very basic question on this.
Starting from head and
Yeah.
rogue spots
Yeah.
in the eye.
Mm.
Janway lesion is a vascular phenomena in the palms of hand.
Okay.
Oscillar nodes, painful,
Okay.
subcutaneous tender nodes.
Mm.
Splenomegaly.
Mm.
Subcutaneous hemorrhage. Nail bed hemorrhages.
Sphincter hemorrhage. Okay.
Sphincter hemorrhage.
Then pallor,
Fever, pallor, weight loss,
clubbing.
hepatomegaly, clubbing.
Clubbing is there. See, you already have 2 of these points in your dental examination. You have to search for other things.
Yes, sir.
Okay, you should not miss out this infective endocarditis. This is a very important part of your diagnosis also, and management also. Okay,
Yes.
this that's one important thing. One more thing, what some examiners expect is signs of aortic regurgitation. At your level, we'll keep it at aortic regurgitation. At higher levels, we call it as diastolic runoff. Okay. Now,
Yes.
signs of aortic regurgitation. Can you tell?
Peripheral signs, Quincke's sign,
Few signs you tell. Just so that others.
Hill signs, variation in BP, pistol shot signs, Quincke's sign on pressing the.
See, best way to remember this
nail.
aortic regurgitation sign is go from head to toe only, like how you mentioned infective
Alternate dilation of the pupil.
Yeah. Keep going. There's multiple signs. Okay. Anyway, that you can read up. Just that I'm telling you that it should be seen. Signs of infection, signs of aortic regurgitation. This in higher levels we'll call it as signs of the diastolic runoff. Okay. Basically, in aortic regurgitation also you have a diastolic runoff. Which are the conditions you have a diastolic runoff? One condition you tell. PDA, patent ductus arteriosus.
Okay.
One more thing is aortopulmonary window. Okay. Yeah, AV fistula. Good. Okay, these are signs of very clear. For example, these patients have diastolic runoff, and make sure you tell signs of aortic. This depends on examiner to examiner, but some people during my MBBS they expect us to tell this. Okay, it depends on your individual hospitals. Okay,
Yes.
so this general examination, infective endocarditis, other signs you have not seen. Anyway, we can't see the patient, but we'll take it as okay, pallor is present, grade 2 clubbing is there. Not very specific for infective endocarditis, but okay. Next. Vitals.
Vitals, afebrile.
Okay.
Pulse 110 beats per minute, regular rhythm, normal volume, normal character, no radiofemoral delay, and no vessel wall thickening. All peripheral pulses were felt.
See here, pulse is very important. Okay, it's one of the most important general examination descriptions. Very important because a lot of information is there in the pulse. I won't go into very specific details of the pulse because you can read that from multiple books. But you should understand when you are told that the patient is having a cardiomegaly, you're told no 6 space patient apex is felt in 6 space. The patient is having mitral regurgitation murmur. You should always go back and check the pulse whether it's hypervolemic or not. Okay.
Yes, sir.
A normal volume with this much cardiomegaly and a pansystolic murmur being present is unlikely.
Yes, sir.
Okay.
Yes.
That you should check always. Regular rhythm you mentioned that you should be certain of it. Okay. Make sure you check it for 1 complete hour. And where you can also have regularly irregular. You know those, no? Can you give some conditions where it's regularly irregular?
Atrial flutter, ventricular tachycardia, ventricular fibrillation, PSVT.
Okay. See, regularly irregular means there are certain ectopics that are coming. Okay. Ventricular tachycardia will be regular, but pulse may be present, may not be present. Atrial flutter, correct, it will be regular. It won't be regularly irregular. Okay. PSVT will be regular.
Yes, sir.
Regularly irregular means there are certain ectopics that are coming.
Ventricular bigeminy.
Correct. ventricular bigeminy, trigeminy, all those things. So how do you differentiate irregular, and regularly irregular? Is again basics, but okay, we'll discuss fast.
Sir?
How do you differentiate irregularly irregular and regularly irregular?
Simultaneous auscultation and palpation of the pulse.
It's called pulse deficit. How is how you differentiate? It's called
Pulse
pulse
deficit.
Yeah, one person has told pulse deficit correctly. Pulse
More
deficit.
than 10 is.
How do you calculate? How do you do pulse deficit? It's a very important thing. They use
2%. Yes, sir. 2% must be there for examination. One person must. Both of the persons should start the examination at the same time. One person should auscultate and find the number of heartbeats. Other should check for the pulse. And if the pulse is more than pulse deficit is more than 10, it's abnormal.
What is it? What is more than 10? What is less than 10? That is the important point.
Less than 10 pulse less than 10 is regularly irregular, and more than 10 is irregularly irregular.
Yeah, more than 10 is AF. Less than 10 is ectopix.
Yes, sir.
Okay, that is an important point that you should know.
Yes.
Okay, they'll usually ask that, and you've not mentioned hypervolumic. Normal character, multiple characters of pulses are there, and multiple mechanisms are there. That depends on what etiology, what probable valve lesion you have. That is mentioned clearly in every books. The mechanisms also are mentioned there. It'll take too long if I mention each pulse, but some specific pulses, if you want to know, water hammer pulse, what is the mechanism?
It's diastolic runoff.
Okay.
Followed by increased end diastolic volume causing water.
See, what happens is in AR, there's increased end diastolic volume. That causes increased force of contraction of the LV. What is that mechanism called?
Frank-Starling.
Yeah, good. Frank-Starling mechanism. Now that causes a bounding pulse. First, the ascending limb is formed.
Yes,
okay, that is the ascending. Now, because of this increased volume, there is a stimulation of the baroreceptors. These baroreceptors perceive it as a high BP. Okay, these baroreceptors perceive it as a high BP. Now, yes, when that happens, there will be decrease in sympathetic activity to the peripheral vasculature. That causes peripheral vascular dilatation.
Yes, sir.
That results in distal runoff. Okay, and one more reason why that's a collapse is there's a regurgitant volume into the LV. Okay, both of this together causes sudden collapse of the pulse. Okay, this is one of the main pulses. And hypervolumic pulse is simple. It is because of increased volume. Because the LV is in volume overloaded, again due to Frank-Starling mechanism, the increased force of contraction causes the increased volume to be ejected into the aorta, causing a hyperdynamic pulse. Now, also in MR, you should understand there are two outlets for the LV. You understood, no?
Yes,
one outlet is to the aorta, one outlet is to the LA. So now if the LA is more severe, there can actually be a reduction in cardiac output. Okay, once cardiac LV dysfunction occurs, the pulse may be normal or reduced also once severe LV dysfunction is there. That is just for your understanding. It will be little too much. You don't have to explain this to the examiner, but just for you to understand what exactly and what the mechanism is. Okay. Now, parvus et tardus and all, you understand, no? There's increase in, that's in aortic, any LV outflow obstruction, static outflow obstruction, that is aortic
prolonged and sustained.
The LV ejection time is prolonged and the cardiac output also is reduced. So you have parvus et tardus. Then what are the other pulses tell? Fast will do. Bisference. Where do you find bisference pulse? Hello? Hello?
Hello, sir. Can you?
Yeah. Where do you find bisference pulse? Okay, a bispheric pulse is seen as severe air or AS with air. One of the mechanisms that they say for that is the wind Kessel effect. What is wind Kessel effect?
The elastic recoil of large blood vessels.
Yeah, the proximal aorta has a lot of elastic fibers that causes a wind Kessel effect that basically dilates and then contracts again. That causes this bispheric pulse. That's one of the mechanisms that is proposed. Okay, then there's one more thing called the dichotic pulse, where there's two peaks, one in systole, one in diastole. The reason for that is it's usually seen in LV dysfunction, and the main reason for
Low
that,
cardiac.
no, yeah, that's correct, low cardiac output. The reason for that is altered myocardial calcium handling. Just remember that if anyone asks. Okay. Altered myocardial calcium handling.
Okay.
Okay, now blood pressure you mentioned. Always make sure in cardiology you check blood pressure and lower limb also.
Yes, sir.
Okay, and don't forget that. That is a very important thing. Make sure you check blood pressure and lower limb. Why is it important?
Difference in pulse pressure, difference in blood pressure in upper and lower arm may signify certain conditions like PDA, aortic regurgitation.
Aortic regurgitation, Hill sign. Hill sign is one of the most important signs in aortic regurgitation because it also grades the severity of aortic regurgitation.
Yes, sir.
You got it, no? So make sure you always measure the blood pressure in the lower limb also. Okay.
Okay. Okay.
Ideally, blood pressure should be measured in both the limbs also. That they also some examiners expect both upper limbs and one lower limb. That is what expected. Blood pressure can be reduced in lower limb for before cooptation.
Yes, sir.
Okay, remember that. Don't forget to measure blood pressure in lower limb. Okay, our respiratory rate is 17 per minute, abdominal thoracic type. Okay. JVP 7 centimeter elevated above the sternal angle. You have to describe JVP a little more.
Okay.
JVP by itself is a class that will take almost more than I don't know how many hours, but you have to understand how to explain JVP. It's very important. Now, if it says JVP is elevated 7 centimeters, how to measure JVP? I hope you know. No need to explain that.
Yes,
yeah. Now JVP, what waves you have to explain what waves are there. That is very important.
Yes, sir.
Do you know how to identify the waves?
Yes, sir.
It'll be difficult for me to explain over phone, but over audio. But okay, just try to tell me what does the A wave signify? What is the X descent? What is the V? What is the Y? Fast.
Hello. Hello.
Yeah, tell. Hello.
Sir.
Yeah, tell me JVP.
There are three waves. JVP consists of JVP is a measure of superficial pressure in the external jugular vein. There are 3 positive deflection and 2 negative waves. A, C, V are the positive waves. A is for atrial contraction, which occurs during systole of atrium, causing the column of blood in the JVP to rise, and there will be an immediate fall, a mild fall during during the flow of blood from atria to ventricle. C is a contracture of ventricle causing tricuspid valve to bulge into the atrial cavity. X descent is due to the downward movements of tricuspid valve, and V is due to passive filling of atria, and Y is due to atrial emptying into the ventricle, right ventricle.
Okay, that is correct. But one more thing, what some books say is C is correct due to bulging of the tricuspid valve into the thing. But some people say it's a corrected impulse to the jugular. Okay, that is fine. Now X descent is divided into 2, X prime and X. Do you know that X prime and X?
Yes,
what
sir.
is X prime?
X prime is actually the tricuspid valve, downward movement of tricuspid valve.
Yeah, correct.
X is atrial relaxation, but
yeah,
it's
correct.
not.
That's not given in all the books. But yeah, good. That is the way how you describe a JVP. And when you see JVP, you should always make sure you see what are the descents. That's what you usually see, no? The descent.
Yes, sir. Yes, sir.
So make in this patient, what was the JVP like? That is very important information for making a diagnosis.
Large A-wave.
Large A-wave.
Yes, sir.
Oh, it was large A-wave, prominent A-wave, you mean?
Yes, sir.
Okay, where do you see prominent A-wave?
Tricuspid stenosis.
Okay.
Right
Now,
ventricle.
before that, in this patient, you are not suspecting tricuspid stenosis, no?
Yes, right heart failure.
No, it is large prominent A-wave is seen in pulmonary hypertension, tricuspid stenosis. Okay.
Yes, sir.
When you give answer, you tell either pulmonary hypertension, tricuspid stenosis. Okay.
Yes, sir.
Okay. Now, there was nothing else in this patient. There's no prominent V wave.
No, sir.
Okay. Now, prominent V wave is important. Why?
It's tricuspid regurgitation may be there.
Yeah. See, now you have pulmonary
Associated with.
See, patient is in failure now. 7 centimeters. Okay, 7 plus 5, almost the patient is having a right atrial pressure of almost 12 to 13. Okay, now patient is in failure. Now the cause of this failure you are attributing to the left-sided heart event, that is mitral regurgitation. That is causing pulmonary hypertension, and that is causing right ventricular dysfunction and elevated
large
JV.
Yes,
yeah, large AV. Now, if V wave is also present, that means there's presence of
tricuspid regurgitation, which adds more LV dysfunction, RV dysfunction.
Yeah, it's a significant pointer towards it's actually a hypertensive TR. It's what is called as hypertensive TR. In patients with pulmonary hypertension, you'll have this thing called hypertensive TR. So that's important. So JVP, make sure you try to explain it to the full extent. Okay.
Okay.
Very important. It's a very important cardiovascular sign. Okay, next.
Inspection. Trachea appears in midline.
Yeah, you read it. I'll just read it out. You mentioned trachea is in midline, say asymmetrical. That is fine. Presence of precordial bulge, you have told. Now, precordial bulge signifies what usually?
Usually, childhood condition which was prolonged.
Yeah, good. That is a childhood condition that resulted in cardiomegaly and was prolonged. Now, see, the thing is, patient you told was had symptoms at 16 years of age. Now, this much precordial bulge means patient has significant cardiomegaly. Now, between 16 years and the last 3 months, now your symptoms started at 3 months. He was completely asymptomatic, according to him.
Yes, sir.
He had no symptoms at all.
No, sir.
Okay. Now, that is usually less likely because these patients will be symptomatic, at least to a mild extent. Okay, anyway, you cannot help it if the patient says that, but usually they will be symptomatic if they have precordial bulge and all. That means that's significant cardiomegaly, and the valvular lesion was quite significant at that point itself. Okay.
Yes, sir.
So when you're giving this, you should be able to explain it.
Yes, sir.
Okay. Then apex beat is seen in the left sixth intercostal space, but medial to midclavicular line. You want to say it's down, but not out.
Yes, sir. Yes, sir. On inspection, it looks so.
Okay. Inspection, it looks like it is in the sixth intercostal space, medial to midline. Okay. No other visible pulsations seen, no dilated vein, no scars and sinuses. What are the visible pulsations you want to see specifically?
Suprasternal pulsation.
For? Before that, what is
epigastric pulsation, left.
No, before ventricular. That. No,
precordial pulsation.
Left second intercostal space pulsation for pulmonary artery. That is important. Pulmonary hypertension, you will have palpable P2. Palpable, yeah, it will be sometimes visible also. So you should not miss that out. Okay. Pulmonary area, pulsations will be seen. Yeah, good. Some people have written that in the chat. Okay. No dilated veins, no scars and sinuses. Okay. These these are fine. These are fine for inspection, but you should know how the weightage of each point. Okay. Okay. Next. Okay, you've written trachea midline. Okay, apex beat is hyperdynamic, skeleton signal on the midclavicular line. Okay, it's down and out. You want to say, then you have to tell. You've written hyperdynamic. You have to tell what type of apex is it. Is it an LV type or an RV type? That is also important. What type is it?
Hyperdynamic LV type, sir.
LV type. How do you differentiate LV type and RV type?
If the apex weight is in one position and it lifts and ill sustain, it is hyperdynamic.
No, pardon me, I did not hear. Can you repeat that?
The apex weight is in outermost and downwards, and the apex weight is ill sustained, it is hyperdynamic.
See, okay, you told LV type because of the cardiomegaly itself. Okay.
So we don't use that LV and RV type. So I'm not sure.
It is to be used. It's mentioned in all the books because what is medial retraction and lateral retraction?
I'm not sure, sir.
See, medial retraction means when it's mentioned in this book called Perloff Clinical Examination. It's also mentioned in Jules Constant and Abrams. If you have Abrams also, you can see it's in precordial examination chapter is mentioned how to find out the type of apex. If there's medial retraction, okay, if there's medial retraction, that means patient is having an LV type of apex. If there's lateral retraction, the patient has RV type of apex. Now, how it is found, how to examine, I won't be able to tell over audio, but there's a specific method called the 3-finger method, and one more method where you put your hand over the parasternal area and one more on the apex and see the cardiac movement. You can actually read it out. It's there clearly given in some books, and it is to be mentioned. In JIPMER especially, I think that we teach like that only. I remember teaching UGs like that.
We don't, sir.
Okay, I don't know what changed now, but yeah, at that time we used to teach. Hamid sir used to teach like that. Okay, now parasternal heave of grade 4 on the left side is felt. Okay, grading of parasternal heave, can you tell?
It's grade 3 actually.
Grade 3.
Yes. Oh. Grade 1 is visible but not palpable. Grade 2 is visible, palpable, obliterable. Grade 3 is visible, palpable, not obliterable.
Okay, so you have a visible parasternal heave. Okay. Now palpable systolic thrill is present where? You have to mention
apex,
where.
Apex. Yes, sir.
Yeah, mention where. Okay. Yes. Then palpable P2 is present. Okay, good. Then epigastric pulsation. Basically an epigastric impulse is present. Okay. So these are your positive findings in palpation. Okay, next.
Yes, sir.
Now, when you come to auscultation, yeah, in UG, you have to mention each area and mention what sounds are seen. So you mentioned a soft S1 in vital area that causes a soft S1 and all you should know, and they will definitely ask you. Then tricuspid area S1 and soft S2 is heard. Okay, because the S2 is away from the tricuspid area, that's why you're hearing soft S2. Otherwise, no other pathology in the tricuspid area. Aortic area S1 and loud S2 is heard. You mean the same pulmonary component is loud?
Pulmonary S1.
Yeah.
Pulmonary component.
Yeah, it's ideal to mention when you mention S2 in the pulmonary area and the aortic area, mention split also. Okay. Mention the split. Usually in pulmonary hypertension, what happens to the split?
Variable split. Why variable?
Yeah, that is varying in respiration. What happens to the width of the split?
Wide.
No, in pulmonary hypertension, what happens? P2 will be early or P2 will be late?
Late P2.
No, it will be early P2 because the pulmonary valve will close faster. Remember that. A2 is always before P2,
yes,
but P2 will occur early in pulmonary hypertension because the valve closes early.
Okay.
Okay, but it will not be before A2. Remember that.
Yes, sir.
Paradoxical slit or reverse splitting, where do you see?
Congenital.
Reverse splitting is seen in very common condition is severe aortic stenosis. Okay, those are mentioned in all books that you should read. But just remember, when you mention aortic area and pulmonary area, you have to mention what is the components, the A2, P2, which is loud, what is the split, and whether it's varying with respiration.
Okay.
That is full S2. Okay.
Yes, sir.
Yeah, that is important. Now, murmur you have described well, correct only, good. Pansystolic murmur grade 4 because you have a thrill, okay.
Yes,
with a loud soft S1, loud S2. You mean to say the P2
no,
is
sir,
heard?
No, sir, no. A soft S1 alone.
Soft S1. You
My mistake.
want to, okay. Best heard in the mitral area in the left lateral position with breath held in expiration, correct? Radiating to left axilla and back with no variation in respiration, heard best using diaphragm and stethoscope. Okay, good. Murmur increases on recumbent position and decreases on standing. Okay, dynamic auscultation. I hope you have you tried all?
No, sir. I tried on standing and exertion and hand grip.
Okay, so usually dynamic auscultation is for differentiating two murmurs. It's not required in all patients. If you have a single murmur and you're sure that it's radiating to axilla and has all the characteristics of mitral regurgitation, usually dynamic auscultation is not required. Okay.
Yes, sir.
Now, if you have two murmurs, for example, you have an aortic stenosis murmur and a mitral murmur, both are systolic murmurs, and you want to differentiate them, how will you differentiate?
Isometric hand grip.
Good. Hand grip. Hand grip will cause what happens?
Accentuation of aortic stenosis murmur.
No, it increases the mitral regurgitation murmur. It decreases the AS murmur. Okay, remember that.
Yes, sir.
Okay, anyway, that is all given in books, but I'm just telling you that this is the basic idea behind dynamic auscultation. Okay.
Yes, sir.
Okay, so go to the next slide. You understood, no? Cardiovascular examination. Any doubt?
Yes, sir. Yes, sir. Yes, sir.
Okay. Next. Do we have enough time? I don't know. I think we exceeded time. Do we have time?
So yes, sir. We can continue.
Okay. 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 So other system examination. You're told
Yes,
normal vesicular breath sounds. Okay. Patient is not in failure. There's no crepitations. Okay. No focal neuronic deficits found. Mild tender hepatomegaly is present. You should also mention whether it's pulsatile hepatomegaly or not.
Non-pulsatile.
Non-pulsatile. Where do you find pulsatile hepatomegaly?
Tricuspid regurgitation and stenosis.
Tricuspid regurgitation, you will have systolic pulsation. And tricuspid stenosis, you will have diastolic pulsation. Okay, good. Now, okay, that should be also mentioned. Also, in other system examination, sometimes you might have pleural effusion. So make sure you actually search for that. Then CNS examination, usually it will be very obvious if any defects are there, if any deficits are there. GI examination, make sure you check for hepatomegaly, splenomegaly, free fluid in the abdomen, and bowel sounds. Okay, these are minimum things. So fast you can finish. Okay, now come to summary.
Summary: a 46-year-old male belonging to middle class presented with complaints of progressive breathlessness and orthopnea, with history of irregular palpitation and progressive non-productive cough worsening in past 2 weeks. And on examination, he had elevated JVP, pitting pedal edema, hyperdynamic apex beat, which is shifted outward, down and out, a pansystolic murmur of grade 4 prominently heard in apex with radiation to back, and parasternal heaving is known. The findings are suggestive of acquired valvular heart disease, mitral regurgitation.
Anything you left out? In your history, you left out.
P2.
Okay.
Pulmonary heart.
In history, you left out exertional palpitation. That's how below placed. Okay. Now, in the examination, you left out pallor, you left out clubbing, you left out P2.
Mild pallor.
Yeah, pallor is there, no, but
okay.
Pallor is there, clubbing is there,
yes,
and history of fever is there. It should not be left out. History of fever is there, no? I mean, not in the present history, past like last
2 months
week.
back.
Yeah, that is also significant. It should not be left out as a simple thing, especially in cardiovascular. You should keep your mind open. Okay.
Okay.
So that is not there. Then JVP you have mentioned, but you have to mention prominent A wave also. Elevated JVP, prominent A wave, pitting pedal edema you have told. Okay. Hyperdynamic apex, shifted down and out. Okay. You have not mentioned thrill. Thrill you have not mentioned, systolic thrill that you had. So make sure you mention all the positive findings in the summary.
Yes, sir.
Okay, history, relevant history, positive findings, and then your diagnosis. Okay, show your diagnosis.
Diagnosis: acquired valvular heart disease of probable rheumatic etiology, mitral regurgitation with pulmonary hypertension and atrial fibrillation with evidence of congestive heart failure without signs of infective endocarditis.
You want to say without signs of infective endocarditis?
Yes, sir.
Okay, but how will you explain the clubbing then? Hello?
Yes, sir.
Yeah. Clubbing, how will you explain?
Pulmonary causes.
Yeah, but your pulmonary examination is fully normal. See, ideally in these cases, no. Usually infective endocarditis, ideally they will not keep in your exam. Okay.
Yes, sir.
They will not keep infective endocarditis. They will usually keep a proper valvular heart disease. But for remember, you in the future when you are actually examining a patient, and after in your internship, MD or DM, whenever you have to write the beginning part of the diagnosis is fine, acquired valvular heart disease, a probable rheumatic etiology. You have to mention the severity of mitral regurgitation. That in MD level, usually you mention. MBBS level is not required, but you should know how it is
Yes, sir.
checked clinically. Can you tell how severity of MR is?
Presence of mid-diastolic murmur in the
Flow MDM. Flow
MDM and
yeah.
S3.
Okay.
Then severity of mitral LVH, left ventricular hypertrophy. Severity of left ventricular hypertrophy.
Okay.
Then according to echo, we'll find 50%.
Clinically.
And that's it.
Okay, see, this patient, what all does he have? There's one more important thing in severe MR that you missed out. That is present. Can anyone tell?
Atrial fibrillation.
No. S3. S3 will be there. Yes, good. Someone has told. S3 will be there in severe mitral regurgitation. Okay. Usually, you have to grade the severity of mitral regurgitation by clinical clinical methods itself, and then confirm it with echo. That is how the usual teaching is. It depends from center to center. Some people will not require to do that, but just try to understand that there are methods, clinical methods, how you differentiate mild, moderate, and severe. Okay. Now you are told pulmonary hypertension. It's again you have to tell mild, moderate, or severe pulmonary hypertension. That is not required at MBBS level. I'm just telling you for your understanding. Pulmonary hypertension you mentioned, and atrial fibrillation you mentioned, but you have irregular. No, you don't have an irregular pulse at present.
Yes, sir.
Okay. With probable paroxysmal atrial fibrillation, you can rate because you have a regular pulse at present now. With evidence of congestive heart failure, that is okay because you mentioned JIP is elevated, and probable infective endocarditis.
Okay.
Okay. Infective endocarditis to be ruled out. That also you can say.
Okay.
Okay. That's how you try the diagnosis.
Okay.
Okay. Now, okay. Now, see, they will ask for your in your MBBS exam. They will ask very simple things. If you have done very well in the history and examination, they will ask some things. How will you manage this patient? Can you just tell what you feel about management? Then I will tell you what else you can add or correct.
So first we'll look for we'll confirm the diagnosis. Echocardiography.
No, before that. There are so many other investigations that should be supposed to be done before echo, no?
The routine blood investigation.
Never.
Blood culture.
Even the exam never directly go to echo. Okay.
Okay.
Examiner will get little irritated maybe if there's some old people, no? They'll for them during that time there was no echo. They were doing everything clinically. So try to explain everything first from the basic investigations. Go up.
Yes, sir. Routine blood investigation, complete blood count, blood culture, LFT, RFT.
Okay. And you should know why you're doing
electrolytes. Yes, sir.
You should know why you're doing each. That yes, I will not go into detail. It's basic only, but you should know why you're doing each. You want to rule out infective endocarditis, that's why you're doing blood culture.
Blood cultures.
Yeah, you have found pallor, that's why you want to see hemogram. You want to rule out any renal failure, pre-renal failure, that's why you're doing RFT. You want to check LV functions because probably congestive hepatomegaly may be present. Okay. You will not have an elevated ESR in heart failure. You should remember that ESR will reduce when there is heart failure. One person was asking elevated ESR. ESR will be reduced in heart failure. You should remember that. Okay. Because of hyperolemia. Okay. Then those are the basic investigations. Then you will do
electrolytes.
Electrolytes. Okay. That's again because of renal dysfunction, and it can be hyponatremia. that dilutional hyponatremia that can be seen in cardiac failure. Then
ECG, chest X-ray.
ECG, okay, ECG, good. So now the examiner might give you an ECG. Okay, we don't have it now, but we'll just discuss. Now examiner will give you an ECG. Now how will you just tell me, how will you describe an ECG?
First we'll look at the rhythm strip and we'll classify into bradycardia, tachycardia.
Okay.
Then axis.
Yeah, good. See, first you have to do simple things. See, there's a way to analyze these things. Rate, rhythm, axis, P wave, PR interval, QRS, T wave. Okay, these are
Yes.
first you see all these things. See,
Yes,
rate, patient will usually be in heart failure, means there'll be tachycardia. Rhythm, you are expecting maybe ectopics may be present, or patient may have atrial fibrillation. Okay,
yes,
so irregular or ectopics may present. They can be atrial ectopics or ventricular ectopics. Okay, then you see the axis. Axis, how to calculate? It will be, if you know, you tell, or else you can just go directly to PR. Do you know how to calculate axis?
looking at the first lead one and AVF if both
Good.
are positive.
Very good. If it's both are positive. Okay, good. Okay, you have an idea. That is a very basic way of finding the axis. One and AVF both are positive, that means normal axis. If one is negative, AVF is positive, that means it's a right axis.
Right.
If one is positive and AVF is negative, it is a left axis. Just a basic, very rough way, because one and AVF are both orthogonal axis, okay, vectors, that you'll learn later when you actually read further. So that's axis. Okay. So in this patient, what will you expect?
Left axis deviation.
Yeah, normal or leftward axis, depending on the cardiomegaly.
Yes, sir.
And what will you find in the PR interval? PR may be normal. If you think there's
multiple P.
If you think there is PR prolongation.
Rheumatic fever.
Yeah, rheumatic fever is one of the causes. Okay. You should remember rheumatic fever. If there's heart failure, the ESR may not be elevated. Remember that. CRP will be elevated, but ESR won't be elevated. Okay. So that is the axis, PR interval. Then you come to QRS. QRS, what happens in, what are you expecting in this patient?
White QRS.
Why you want to say white QRS? See, what happens is this patient will have LV volume overload. Okay. Volume overload. So what are the features in ECG that says as LV hypertrophy? This I think you would have read. In LV hypertrophy, there are some criteria. The multiple criteria are there. Anyway, it'll be too much for you, but just remember that if there is, look at the R wave in V6 and
RV6 and SV3.
Yeah, some people have written good. Sokolov-Lyon criteria, LV strain pattern. Yeah, very good. So multiple criteria are there. So that you see the R in V6 plus the S in V1. If it is more than 35 millimeters, that means left ventricular hypertrophy is present.
Okay.
Again, there are two ways to differentiate if it's a volume overload or pressure overload. That again, it will be, if you tell during the exam, examiners will be very happy, because during my MBBS level, even I didn't know all this. I'm just telling you because I have the opportunity to tell you. Q wave, if you find a Q wave in V5 and V6, if you find a Q wave in V5, V6 without ST depression and T inversion, that is most likely pointing towards volume overload. Okay.
Yes, sir.
Now, if you find an ST depression and T inversion, asymmetrical T inversion is what is called in V5, V6. That goes in favor of a LV pressure overload. Okay. LV strain pattern it's called. Okay.
Yes, sir.
So that is ECG. So you have to search for left ventricular enlargement and left atrial enlargement. Atrial enlargement, what is the P mitral? Good. So that is that you see in which lead?
Lead 1.
V1. Okay. V1. That's where you see. So then you have to see for other possible chamber enlargement. What other chambers can be enlarged?
Left ventricle.
We told left ventricle, left atrium. We finished then.
Right ventricle.
Right ventricle, good. Right ventricular features on ECG are also present. There are multiple things. Then you see the R by S in V1 if it is more than one. Multiple features are there. You can read up if you're
Yes.
interested. Okay, then you have to
Yes,
see
sir.
right atrial enlargement. Okay, that is the final thing. Usually, right
Yes, sir.
atrial enlargement is last to right atrial enlargement is last to occur in mitral diseases. Okay,
Yes, sir.
okay, that is ECG. Then ECG is much more, but these are the basic things. Then you come to X-ray. What all they might show you an X-ray. Now describe the X-ray. How will you describe?
Uh, First norm APV,
It will
chest
be
X-ray,
usually AP view or PA view.
PA view,
PA view. Good.
exposure, normal
Exposure.
exposure,
Okay. How will you determine
rotation
exposure? If it's normal or increased or decreased?
based on the vertebral shadows,
Yeah. How
vertebral
many?
body.
You should see at least till fourth vertebrae.
Eight.
At least
Yes,
four
sir. Yes, sir.
vertebrae. Okay. And then
Yes.
what else you will see?
Rotation,
Rotation. Good.
penetration.
Yeah, that any exposure you told. Okay. Then you'll tell about the bony cage. Comment on the bony cage, if it's normal or not. If there's any gross abnormalities in the ribs or the spine first.
Yes.
Then you come to cardiac shadow. Cardiac shadow is a cardiomegaly or not? How do you find out cardiomegaly is there or not?
Cardiothoracic ratio
Cardiothoracic ratio,
more
good.
than 60%.
More than 55. Okay,
50.
more than 55 in adults. Remember that. Okay, then you will see other chamber enlargement. How do you find if it's left atrial enlargement or right atrial enlargement? Left atrial enlargement, how do you find?
Left atrium will enlarge posteriorly, so in lateral X-ray you can see walking mention.
See, left atrial enlargement, one way of finding. See, first thing there will be left atrial appendage enlargement that causes a straight left heart border. Okay, in these rheumatic heart disease patients with mitral lesions, mitral stenosis, they usually have a straight left heart border. That's the reason. Then there's left atrial enlargement. Left atrial enlargement causes playing of the trachea. Okay, there'll
Yes.
be a very obtuse angle between the carina where the trachea bifurcates. That's called splaying of the trachea. Then right heart border, you will have a shadow in shadow appearance. This you can all read. It's there in Harrison's under the mitral stenosis or mitral regurgitation chapter. It's given very
Okay.
clearly. You
Okay.
can read a chapter. You will understand it very well. There are multiple diagrams. I don't have those photos here, so you can tell those. Okay. Then you have
What is
to
Ortner syndrome, Sukumar?
yeah
So,
tell.
compression of recurrent laryngeal nerve due to left atrial enlargement causing reduction in voice, harshness of voice.
Very good.
Good.
Another important question now. What you don't know, tell me. One thing. What you don't know. You're doing very well, Sukumar. Wonderful, you're doing.
Yeah,
Okay,
yeah.
both the discussion is going very well. It's doing far better than even PGs also. Wonderful.
Yeah,
All
it's
of us are
very,
enjoying. Please go on. Please, yeah, Karthik, please.
Thank you.
yeah, yeah, it's very good. Actually, at MBBS level, trust me, I did
Even
not
I
know.
learned a lot of things today. Even I learned a lot of things from Sukumar today. Wonderful.
Yeah, it's very good. At MBBS level, trust me, I did not know this much. So it's very good. I hope you get encouragement to read more.
Yes, sir.
So,
Yeah.
okay, left atrial enlargement, you will see a shadow in shadow appearance of the right heart border. Okay.
Yes, sir.
So that is one more way. Then right atrial enlargement, there are multiple criteria. It can be right atrial shadow extending more than 3 rib spaces. That is right atrial enlargement. Okay.
Yes, sir.
Now
Yes, sir.
right ventricular enlargement is very difficult to tell in the X-ray. Okay, because you
Yes.
have a cardiomegaly, already a left ventricular enlargement. You already have a cardiomegaly. It's very difficult to tell right ventricular enlargement. Okay. So X-ray, what else you will tell? You will then see the lung shadows.
Lung,
Lung shadows, what will you have?
pulmonary congestion,
Yeah,
plethora.
what is that called? What are the different gradings? See, in Algopan mitral stenosis part, they have explained very well what is the different gradings, what will you find first, what will you find second, what will you find third. First, you will have cephalization of the veins. What is that?
The bronchial arteries will be prominent.
Cephalization of veins. Cephalization of veins. Basically, pulmonary veins. No? You're talking about pulmonary congestion. That is pulmonary veins. Okay, pulmonary veins will be more prominent in the apical lobes.
Okay.
Okay, so though that is called curly. You heard of these curly A lines, B lines, C lines?
Yes, sir.
Yeah, these are curly A lines. Then curly B lines. Curly B lines will be horizontal lines to the diaphragm or the base of the lung. Okay.
Yes, sir.
Then curly C lines are towards the hilum.
Bronchial.
Okay.
Yes, sir.
Then there is frank pulmonary edema, which is cottony, fluffy opacities bordering around the hilum. That is pulmonary edema. Okay, that is basic about the X-ray. So echo will be a little too much for you. If you know what all to see in echo, you can tell.
Left ventricular ejection fraction.
First, before that, left ventricular dimension, left ventricular
Dimension.
ejection fraction. Then you want to see severity of
Structural
MR.
anomalies.
Good. Yeah.
Leaflet.
Yeah. Good. You want to see if it's a mitral stenosis, if it's rheumatic or not. There are specific things in echo how to say if it's rheumatic or not, so that you can read up. If you want, I can tell you. See, there will be mitral valve with a specific deformity in rheumatic heart disease. That is classical. Almost all patients with rheumatic heart disease will have it. They call the posterior mitral leaflet will be fixed, and the anterior mitral leaflet will be bowing. Okay. Now this is classical. This much you remember, it's enough. If you tell this much, they'll be very happy. Okay.
Yes, sir.
Then mitral regurgitation, the mitral regurgitation jet you will be seeing. You can see the severity of mitral regurgitation. Then you will check pulmonary artery pressures, all those things. So that just know that echo is for LV dimensions, LV ejection fraction. Assess the mitral valve and mitral regurgitation severity and pulmonary artery hypertension. Okay.
Yes, sir.
Okay. Now, how will you manage to treat this patient?
The patient have mitral regurgitation, so there will be increased chance of infection. So antibiotic prophylaxis will be given.
Okay.
The patient is in atrial fibrillation, so warfare anticoagulant along.
He's not in atrial fibrillation, but patient has likely episode of paroxysmal AF. Now that you should confirm before actually starting a patient on anticoagulation. Okay.
Yes, sir.
Ideally, what we do is a Holter test. Okay, a Holter test. One person has asked CHADS2-VASc. CHADS2-VASc is not used for valvular atrial fibrillation. It's used for non-valvular atrial fibrillation. You should remember, it is not used for valvular. Valvular atrial fibrillation, you have to give anticoagulation. Okay. Now,
Yes,
what are they saying? Yeah, atrial fibrillation. You have to confirm because the patient is not having currently atrial fibrillation. If there's any documentation of AF at any time, then you're sure it's paroxysmal AF. You can do something called a Holter. A Holter is you know what a Holter is?
No, sir.
Holter is, it is a small machine which you attach to the chest and you check and you attach leads to the chest and it's connected to the patient for 1 full day. And it checks the ECG for the entire day, 24 hours. Okay.
Okay.
So that is called a Holter. If they detect arrhythmias, atrial fibrillation, any VPCs at that time, then you can start particular treatment. You need some proof that the patient is having EF. Okay. Then what else? How will you manage?
Then there is likely chance of the patient is in congestive heart failure, so diuretics and beta blocker may be.
Management of heart failure. Okay. Then you have managed the heart failure. Patient is now asymptomatic. How will you manage this valvular lesion?
Valvular lesion will do surgery if the patient is severely symptomatic.
Good.
Valvuloplasty, mitral valvular repair.
Okay. First, you have to know that the patient is having severe MR or not. Most likely severe MR because of symptoms and everything. Even as clinically also, we are most likely pointing towards severe MR only. So he has severe MR and is symptomatic. If LV dimensions also are increased, LV dimension most likely will be increased in this patient. If LV dimension also increased, then you have to do a mitral valve replacement. Okay. Now mitral valve replacement or repair. Okay, those are the two possible. If you tell this, it's enough. But if you want to go further, how would you choose which valve to use? Prosthetic? Do you want to use a prosthetic or a metallic valve? Do you know how to choose?
For long term, we'll use prosthetic valve, and for a old age patient, we'll use bio.
Yeah,
native.
correct. Yeah, correct. You will use you'll use these uh, what metallic
Biological
valves.
valves.
Yeah,
Yes.
metallic valves for patients who are younger and who require a prolonged duration of anticoagulation. Okay, because they will require, because these bioprosthetic valves can degenerate within 10 years. Remember, that is
Yes.
the concept.
Yes, sir.
Bioprosthetic valves degenerate within 10 years. That's why metallic valves are placed in younger individuals. In elderly individuals between 50, 60, ideally recommendations say at 60 years, we use bioprosthetic valves.
Yes,
Okay,
sir.
so that's how we manage this patient. Okay, that's very good. You presented very well. We had a good discussion also, I think.
Thank you, sir.
Yeah, it was nice. Kishan?
Excellent. In fact, Dr. Karthik, I should admit that this was one of the best presentations we had in the White Army. Excellent. He did very well, and he kept up the reputations of JIPMER, being a JIPMER student. And
Yeah,
really, we are happy and proud of you, Dr. Sukumar, Mr. Sukumar.
Thank you, sir. Thank you,
I
sir.
think you are already tired.
yeah, it must be. Yeah, I
And
think yeah,
Dr. Karthik has really made it very high standard discussion. No, he had kept it very high standard. Okay, because see, it's always mutual. If you are answering, even the examiner will get that interest to
yeah,
ask you more and more and better and better. It's always mutual. Okay, if you are not answering the basics, you answered all the basics very well. So he got interest to teach you further and teach you better. Okay, so everything depends on the student, where you take it, how you take it. So you did a brilliant job, Mr. Sukumar.
Thank you,
Really,
sir.
frankly telling you, yeah, okay, it was far better than even a PG discussion. Good. Okay,
Thank
and
you, sir.
any help, yeah, now, and you more than that, everything is your own senior as well as a teacher there from JIPMER. You can any help anytime. He will be
Sure, sir.
very pleased to help you. Okay, this is the
Yeah, sir.
advantage
Sure.
also. Presenting in such national forums, that's the advantage. You get to know many people, many mentors from outside also like this. All so many advantages. Try to keep presenting like this. Okay,
Yes,
because
sir.
of you
Sure.
see, so many of us learned many things today. Okay, even in exams, if you this is the not even the 50 in your exams, this will be not even 50% of this much what you answer today. If you answer like this in exams and all, it will be very easy for you. Okay,
Yes, sir.
good. Dr. Karthik, any concluding remarks?
that's it. It was a very good presentation by Sukumar. I'm actually very impressed at the MBBS level. I'm sure I did not know all this. And it was a very nice discussion also. I think you should keep it up and read as much as possible and more. Okay. Any
Thank
other
you, sir.
doubts that you have, you can always tell me
Yes,
anytime.
sir. Sure.
I think I
Sure,
know
sir.
all your seniors who are there and who are there in medicinal or medical seniors there. I can follow them. So it was a
Yes,
very
sir.
nice discussion. Keep it up, man.
And one
So,
Yes,
more
sir.
request,
Sure.
Dr. Karthik,
yeah.
whenever you're free, please take some sessions for us and take some clinical presentations.
Yeah, sure,
Do
sure.
the mentoring like
Anytime.
this. Like
Yeah,
it was really good discussion for. I learned a lot of things. And again, those who couldn't attend the session will be again going through the YouTube videos. It's recorded in YouTube. So as and when we require during examination for revision and all, we can use these videos. So this will be very helpful for us. So please, whenever you feel like a little convenient, please take us some sessions. It's kind request from all the members. Okay.
yeah, definitely. When I'm free, I will definitely do. No problem. Thank you.
Yeah. Yeah.
Thank you so
So
much.
any
Thank
Thank you,
you
doubts,
for
sir.
this
members? Yeah.
opportunity. Thank you for this opportunity. It
Yeah.
was nice
Yeah.
to
No mention. No
talk
mention.
to so many
Yeah.
people and discuss this. It was nice. I liked it.
Yeah.
Thank you, sir,
So
for the
let's
same
conclude the session.
opportunity. Yes, sir.
Yeah. Let's conclude this session. Thank you once again for the mentor, the